Good day to everyone joining us, and welcome to today's X Talks webinar. Today's talk is entitled From Symptoms to Solutions Enhancing Interstitial Lung Disease Trials with Next Gen Assessments. My name is Sonia Hunt, and it's my pleasure to be your X Talks moderator for today. Today's webinar will run for approximately 60 minutes. This presentation includes a Q&A session with our speakers. This webinar is designed to be interactive, and webinars work best when you're involved. So please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. Now, this chat box is located in the control panel, which is found on the right-hand side of your screen. If you require any assistance, please contact me at any time by sending a message using this chat panel. I'd also like to welcome our attendees viewing this presentation from our LinkedIn Live event, and I encourage you to submit questions as well via the Comments tab. At this time, all participants are in listen-only mode. Please note that this event will be recorded and made available for streaming to those who register on xtalks.com. At this point, I'd like to thank Clario, who developed the content for this presentation. Clario is a leading provider of endpoint data solutions that generate high-quality clinical evidence for their pharmaceutical, biotech, and medical device partners. They offer comprehensive evidence generation solutions that combine ECOA, cardiac solutions, medical imaging, precision motion, and respiratory endpoints. Since their founding more than 50 years ago, Clario has delivered deep scientific expertise and broad endpoint technologies to help transform lives around the world. Clario's endpoint data solutions have supported clinical trials over 26,000 times in more than 100 countries. Their global team of science, technology, and operational experts have supported over 60% of all FDA drug approvals since 2012. Now, it is my pleasure to introduce our speakers for today's event. And first, I'd like to introduce you to Dr. Todd Lestine, and there he is. Hi there, Todd. Todd has over 25 years of clinical leadership and pharmaceutical industry medical safety experience. Prior to joining the industry, he spent 17 years in clinical pulmonary critical care medicine, serving in various leadership roles. Over the last 9 years in the pharmaceutical industry, he has held medical safety leadership roles at large and mid-sized companies. He currently oversees the medical science respiratory division of Clario. So there he is. All right, next, it's my pleasure to introduce you to Kevin McCarthy. And Kevin should be joining us here now. Hi there, Kevin. So Kevin is the Scientific Affairs at Clario, Senior Director of Scientific Affairs at Clario. And Kevin has 50 plus years in lung function testing with 40 years managing Cleveland's Clinical's pulmonary function laboratories and brings extensive expertise to clinical trial data quality. His passion for accurate measurement is backed by his experience in managing pulmonary function control or quality control for 2 NIH-funded registries. And next, I'd like to invite Dr. Amit Vasanji. He's a Vice President of Medical and Scientific Affairs at Clario. Amit has 20 plus years of experience, hi there Amit, of experience in basic and clinical research imaging, including acquisition, processing, analysis, and software engineering across various modalities and therapeutic areas. A published researcher and frequent speaker on image workflow and biomarker development, he currently oversees the scientific design of Clario's imaging platform. And next, I'd like to welcome Dr. Peter Cho. He's the Adjunct Senior Lecturer, King's College Hospital and King's College London. Hi there, Peter. Peter is a respiratory consultant at King's College Hospital, specializing in chronic cough, trained in London and Southeast England. He holds a PhD in cough physiology, and is an investigator for the European Respiratory Society NeuroCough Registry. Now, with the introductions out of the way, it is now my pleasure to pass the mic over to Todd. So Todd, when you're ready, you may begin.
Thank you, Sonia, and thank you, X-Talk, for the opportunity to present this important topic. I'd also like to thank those attending today. We really look forward to providing insights in this important topic. There's a lot to cover, so I'd like to just jump right in. Before I use the agenda for today, we'll start with my giving just a bit of background on interstitial lung disease as an introduction. I will then turn it over to Kevin, who will talk about lung function measures and some unique means by which we can apply ATS-ERS standards that might help facilitate clinical trial eligibility. He'll also talk a bit on ECOA in interstitial lung disease. Thereafter, we're going to turn it over to Peter Cho to give us some insights in cough, particularly expanding on the subjective capture of this important symptom for these patients, giving an opportunity to obtain this information objectively as well. And then we'll shift over to Amit, giving us some insights into centralized imaging applications in interstitial lung disease clinical trials. We'll then transition to an opportunity for a quick wrap-up and some Q&A thereafter. Next slide, please. So, next slide. So what is interstitial lung disease? This is an umbrella term that we use for approximately 200 subtypes of varied diseases, a range of different conditions with varying triggering pathophysiologies. In this case, pulmonary alveolar walls are infiltrated with varying degrees of inflammation and inflammatory cells, fibrosis, and there's also abnormal proliferation of cells that normally make up alveolar walls. This results in an impact on the patient where there's significant gas exchange lost, hypoxemia is prominent, patients become dyspneic and have diminished activity tolerance as a result. And this is further complicated by this chronic debilitating cough. It's of increasing awareness of importance to these patients. All of this translates into significant loss of quality of life. Patients may progress through right to respiratory failure. Objectively, we'll identify these issues with pulmonary function showing a restrictive process and a loss of diffusing capacity. And then there's also characteristic imaging seen. There are multiple means by which to categorize these conditions. Those that are related to distinct diseases, these include diseases such as eosinophilic pneumonia, sarcoidosis, lymphangioliomyomatosis. There are also those related to environmental exposures. Prominently, we think in terms of hypersensitivity pneumonitis, which represents approximately 15% of interstitial lung disease. This is a disease that is a result of exposure to organic proteins. There's also those primarily due to occupational exposure to inorganic dusts. These are the pneumoconioses. There are also drug-induced interstitial lung disease. Classically, we think in terms of amiodarone, bleomycin, and increasingly recognize the cancer immunotherapies. The more common categories are those that are associated with connective tissue diseases. These account for approximately 25% of interstitial lung diseases. Classically, we think in terms of those associated with systemic sclerosis or rheumatoid arthritis. And then there's the idiopathic category, and this includes nonspecific interstitial pneumonitis, NSIP. And then there's the archetypal ILD, and that is idiopathic pulmonary fibrosis. This is the most common entity, impacting or accounting for greater than 30% of interstitial lung diseases. This disease process is characterized by usual interstitial pneumonia pattern seen on imaging and on pathology. And as the category name implies, there's a lack of an identifiable cause or triggering disease associated. There's a very poor prognosis with IPF. Mortality is in the 2 to 5 year range from the time of diagnosis. It's a disease that's most commonly occurring in those that are a bit older, greater than 60 years, and there's a bit of a male predominance in this disease process. That differs from the other interstitial lung diseases, which are generally in a younger patient population with a more balanced male to female ratio. Very importantly, those other diseases can transition into progressive pulmonary fibrosis. This is where There's more of an IPF-like pattern of behavior, sustaining fibroblastic activation, differentiating into myofibroblasts, orchestrating fibrogenesis, and then there tends to be a feed-forward loop of self-perpetuating fibrosis. And so not just pathologically and radiographically, but also in terms of clinical pattern, these patients start to behave more and more like IPF. Next slide, please. Epidemiologic data for interstitial lung diseases is somewhat inconsistent, making it a bit challenging to fully appreciate the ILD landscape. A range of prevalence has been reported, as you can see in the first bullet point there. It is a growing global health issue. There was a reported increase by 86% in ILD-related years of life lost over the 2 decades leading up to 2017. And in the US, most recent reporting indicates approximately 650,000 individuals affected, resulting in approximately 25,000 deaths per year in the US. Treatment is primarily directed at when an identifiable trigger is there, when there's connective tissue disease, directed immunomodulators appropriate for the underlying disease is appropriate. Removal of offending agents, of course, when there's exposure-induced ILD. Supportive care is almost always recommended. This would include oxygen therapy where appropriate and pulmonary rehabilitation. Certainly as either IPF or PPF advances towards end-stage disease, lung transplantation comes into the discussion. And then there are the antifibrotic agents. We're fortunate to have these. They've been available for about the last 10 to 15 years. They are shown to slow the progression of fibrosis, limiting fibroblastic activation and proliferation, truncating collagen synthesis, modulating oxidative stress, and transforming growth factor beta, ultimately diminishing the immune response. Pirfenidone is labeled for IPF only. Nintedanib is tyrosine kinase inhibitor. This one's been labeled for IPF in the US and also PPF due to systemic sclerosis-associated ILD. Interestingly, more recent work has indicated that, at least in the case of nintedanib, there is some application in other connective tissue diseases, including rheumatoid arthritis and mixed connective tissue disease. Both are effective in reducing the rate of decline in FVC, forced vital capacity, and the risk for acute exacerbation. Next slide, please. This brings us to clinical development. Pulmonary function testing and imaging, they still remain the primary validated endpoints relied upon by regulators when it comes to market authorization. We at Clario can recommend, I've already sort of mentioned, we can recommend an amended approach, particularly with regard to spirometry. They can help optimize enrollment and minimize participant burden. Also, as far as the importance, including in regulators and payers, there's increasing attention to the patient's voice and their experience. How does the patient feel? How do they function? We utilize patient-reported outcomes, ePROs, eCOAs, to diminish participant burden. And I've already mentioned this cough issue. This is an increasingly recognized issue of importance to patients as they experience these disease processes. And we have means by which to augment understanding of the impact on the patient beyond the patient's recall through diaries, but also by objectively capturing this through advanced technologies. So with that, I'd like to turn this back over to Kevin to expand on the discussion of pulmonary function testing and eCOA.
Thank you, Todd. So as Todd mentioned, that lung function can provide outcome parameters for clinical trials for ILD. Next slide, please. And we're going to focus on some aspects of those measurements that can be tweaked, so to speak, to improve eligibility for clinical trials. So what's important? The changes associated with ILD result in the lung stiffening and effectively shrinking. And so the total volume exhaled after a maximum inspiration, the vital capacity provided by spirometry, is the most often followed parameter. And with spirometry, you also get an FEV1, which may not be as important in most interstitial lung diseases, but is helpful for excluding a subportion of the patient population with ILD that has significant concomitant airway disease because they have that pre-existing other disease. It's a little difficult to tease out what's going on with the ILD if they're included in the clinical trial. And Todd also indicated that gas exchange efficiency is impacted by this disease. There are changes at the alveolar capillary level that often result in low oxygen levels. And there's a measurement called diffusing capacity of the lung for carbon monoxide, or DLCO for short, that provides a good way to track those changes. And so on the left-hand side of the screen, you'll see there's a couple of devices there. On the top is Clario's Spirosphere spirometer. That's kind of the workhorse that's got its touch screen, wireless sensor. It's got a lot of bells and whistles that really facilitate and really aid the operator in obtaining good quality measurements. Below that is the device used to collect DLCO. And if you want to standardize that equipment, Clario can provide that through a relationship with one of our partners, NDD. That's the NDD Easy one there. Next slide. So I really do not want to get into a lot of technical details, but it's a little bit unavoidable. Anybody that's done spirometry that's on this talk right now or has even witnessed one will realize that the description of it sounds simple, but the execution really, you find out that it's really not that easy, both to even do it, but to do it in a way that gives you quality measurements that really reflect what's going on in the patient's lungs. And because the patient is critical, that is, they really need to cooperate and give it maximum effort, there's an interaction going on between the operator, the patient, and the measurement device that really can play a strong role in getting good quality data. So what constitutes quality? I mean, anybody can blow into a spirometer, but doing it in a way that gives you good quality measurements, the details about that are provided in international standards called the ATS-ERS standards that are updated periodically. And what I don't want to do is turn this into a talk that goes through those, but there's one that I think provides us, it's a pain point in clinical trials for ILD, and we have an opportunity there. It's called the back extrapolated volume standard. And typically those that know spirometry know that that's helping guarantee the quality or assure the quality of the FEV1 by making sure that the patient is really exhaling briskly from full inflation the moment they start their exhalation. Now, a little bit of leeway is granted by this standard. And so what you're looking at on the right-hand side of the screen are two different forced vital capacity measurements depicted in a volume time tracing. The top one is perfectly executed. You can see at time 0 where that vertical black line is. That's where air starts going into the spirometer. You can see it entering in very quickly. And as the lung empties, you expect to see what you see here is that it slows down gradually and eventually gets to the point where even though the patient's pushing, you don't see any more air coming out. That's how you know you've got it all. So the bottom panel there is showing the circle part of it shows a little bit of air was entered into the spirometer well before time 0. That time 0 is obtained using a back extrapolation technique. That's why this volume to the left of that vertical line is called the back extrapolated volume. It's how much was blown out before they applied maximum effort. And without getting into too much detail, there's the one thing I do want to say is that the new standard said you should apply that back extrapolated volume criteria to the FVC acceptability as well. Well, at Clario, we kind of advise against that for two reasons. First, we've always taken care of what the standard was meant to prevent, which is reporting a slow vital capacity as a forced vital capacity. There can be a difference between those two numbers. I'll explain more about that in a little bit. But Clario has taken care of that just fine with respect to forced vital capacity. And we advise clients to turn off the back extrapolation volume standards or flags rather for the FVC because they're really more of an annoyance for the operator. Next slide. it's not uncommon to see back extrapolated volume be present in clinical trials for ILD, because the stiff lung of ILD is kind of like a really stiff balloon. The moment you move your lips away from the balloon, it wants to drive the air out with a lot of force. When you fill that lung up, and you put you have the mouthpiece in your mouth, it's easy to leak out a little bit while the operator is, before they tell you to blow. But there's an important aspect to it as far as FEV1 acceptability goes. It does serve utility for that. And in clinical trials for ILD, the FEV1 is primarily used at screening visit to identify patients that have significant airway disease. And in the newest standards for spirometry, the back extrapolated volume, the lowest allowable, when you have really small lungs, the maximum allowable rather, was reduced from 150 mLs to 100 ml. That change was kind of driven by the thought that, well, if 150 ml is good, 100 ml is better. It was not data driven. It was a consensus of expert opinion. And to date, I'm not aware of any study that shows the impact of this change on the accuracy of the FEV1 data, but I can tell you that in the clinical trial world, we've seen, particularly in studies where you have patients with small, stiff lungs, that we see a lot of patients producing efforts that meet the old standard but fail the new one. And as I said, nobody's really examined that, although we have. I can't share that with you right now. We're hoping to present that at ERS, European Respiratory Society meeting this year in the fall. But I can tell you with confidence that relaxing that volume standard back to where it was in 2005 is not going to result in an inaccurate FEV1. So next slide. So what that means is that when you start using the FEV1 at screening visit to identify obstruction, you're using it as a ratio of the FEV1 to the FVC, which is really, what percentage of the total volume you exhale were you able to get out in 1 second. So it's if you have airway disease, your lungs don't empty as efficiently, and that FEV1 to FVC ratio is reduced. So that's a good thing to identify right up front. The problem comes is that virtually every ILD protocol that I've seen uses the GOLD criteria to set the bar as to how you identify airway disease rather. They use a fixed lower limit of 0.7, meaning if you exhale less than 70% of the total volume in the first second, you have obstruction and you shouldn't be in the clinical trial. Now that practice of using the GOLD criteria has some applicability for clinical decisions, but the interpretation of PFT data using that fixed limit to identify obstruction is strongly discouraged by international standards. And the reason for that is a good one, is that it tends to undercall obstruction in the young and overcall obstruction in the elderly. And we see many elderly patients with IPF and other ILDs that show a ratio less than 0.7, but the ratio that they do exhibit is above their predicted lower limit of normal. So again, I have data on this. We submitted an abstract to the ERS 2025 that we hope to share with you when that becomes available for you. But this is probably the most important slide that I can share with you today, is that this has a big impact on reducing the number of screen failures that are inappropriately flagged as having airway disease when they actually don't. Next slide. And then I'd like to just introduce the concept of novel endpoints, spirometry endpoints in ILD studies. So on the right-hand side of the screen is a volume time tracing showing what you'd see in a forced vital capacity maneuver. And there's 4 phases to it shown here. Prior to the 2019 spirometry standards, there were only 3. So the patient would take a big, deep breath in, that's 1. They would blast the air out, that's 2. They would keep blowing till they got all their air out, that was 3. And that's where it ended. But in 2019, we added the 4th phase, the rapid inspiration back to full inflation. And the reason for doing that was to provide an objective means for evaluating answering the question, did that forced exhalation really start from full inflation? And just as you see here on the screen, that the FVC, the exhaled volume, and the FIVC, the inhaled volume that occurred afterwards, those are equivalent. They share common endpoints. The end of the forced exhalation is the beginning of the forced inhalation, and they should be equivalent. So in a clinical trial where you're looking at FVC, you use the FIVC to say, nope, you shouldn't report that FVC. It didn't start from full inflation, and that's the number one requirement. What I'm proposing is that as a secondary or an exploratory outcome, you'd use VC max, the larger of the two, meaning if you have a measurement where every effort showed FIVC to be larger, rather than suffering a missed data point, this analysis would use VC max, the FIVC, because it's a measure of vital capacity. And what you'll end up with is fewer missed data points and slightly higher mean values at the end of the study. So. And also, I'd like to introduce the notion that SVC, which is not typically, it's an easier to perform version of measuring the vital capacity than the forced vital capacity, not typically done in spirometry, and likely why it's not named as the parameter to follow. It still provides a valid measure of vital capacity, and in other studies, like those with neuromuscular disease, we have some experience where it's less of a burden on the patient and the site. Next slide, please. And so this is a summary. I won't go over it again. We just did that. But basically, I just wanted to point out that the net effect of all of these is to reduce the patient and the site burden by reducing the number of efforts needed, reducing screen failures, and missed data points. And so I'm going to shift a little bit, next slide, please, from the pulmonary function aspect of clinical trials to what Todd had mentioned, that the FDA is very interested in collecting information about how the disease is impacting the patient. How are they feeling? And so clinical outcome assessments can be, when you do them, next slide, please. This slide shows a bunch of different clinical outcome assessments that get at their various aspects of what the patient feels, the dyspnea, their shortness of breath, their cough, their quality of life, and even performance outcomes like a 6-minute walk. You have the option, if you're collecting any of these, of collecting it via paper, or, next slide please, you can use what we can provide as an eCOA handheld that has a lot of advantages. It actually triggers alarms based on the protocol to tell the patient when to complete these questionnaires, because they're completing them in near real time, or on a regular basis, scheduled basis. You avoid issues that typically occur with paper. So number one, these devices are a whole lot easier than using a paper instrument. Number two, they're going to be completed on a timely fashion, so you don't have what's known as the parking lot effect, where the patient is completing a handful of questionnaires that should have been done over the past weeks while they're in the parking lot getting ready to come in and see you. And the data, when completed, is daily transmitted to Clario, so you get an accurate and timely picture of what's going on with each one of your patients during the trial. And with that, I'm going to turn it over to my friend and colleague, Dr. Peter Cho. And Peter's going to share with us his expertise about cough in clinical trials, and particularly in ILD. Thank you, Peter.
Thank you, Kevin. Hopefully in the next 10 minutes, we'll talk about cough, and hopefully we'll convince those of us here that cough is not just a symptom, but it's actually potentially a phenotype and a quite important feature of ILD. And so the first thing to say is cough is actually quite common. It affects up to 81% of patients with ILD. Most of the data that we have is in IPF in terms of what it means to the patient. And I think that's a good point to start with, is what cough really means to the patient, what the impact is to the patient. Cough is actually quite impactful, and the diagram demonstrates it quite well. It affects patients in many different ways, and cough in ILD is associated with worse health status, and in particular, in an Australian registry study of IPF, cough severity VAS is a subjective tool that we can talk about a little bit more. And what it means really is that we just measure the severity of the cough 0 to 100. And with that severity score, cough severity is associated with general respiratory health status measured by St. George's Respiratory Questionnaire. Next slide, please. I hope that demonstrates that cough is impactful and important to our patients. What does it mean clinically to us? Um, ILD patients with cough, they have worse disease severity than those without, and that's measured by FVC, gas transfer, and 6-minute walk distance. So not just the disease measurement, but also their exercise capacity. We also know that cough-specific health status has an ability to predict hospitalization, mortality, and transplantation in patients with ILD. And this data was obtained from a large registry study in the US with almost 1,500 patients with ILD. More recently, last year, there was a paper published in Blue Journal, and what that paper has shown is by Phil and G in Imperial College London is that in patients with IPF, cough severity measured by VAS, a cutoff of only 30. So anything greater than or equal to 30 has a much worse survival rate. And the Kaplan-Meier curve demonstrates that beautifully. And to put it in perspective, the number 30 means that the cough is actually only mild in severity. So patients with mild severity cough in IPF have worse survival outcome. So I'm hoping that so far I've demonstrated that cough is impactful to our patients, but also clinically to us. Cough also potentially is a phenotype associated with disease severity. Next slide, please. So obviously, with cough being quite impactful and potential phenotype, we're interested in knowing what causes a cough. Unfortunately, we're still not quite sure. What we do know is some data from Ben Hope-Gill and previous data as well in London is that there's what we call cough reflex hypersensitivity. So the reflex arc is sensitized. So the amount of stimulus required to set up cough in patients with IPF is much lower than that compared to healthy individuals. We've also we've got some data from patient-based survey from Action for Pulmonary Fibrosis, which is a charity in the UK, demonstrating that patients also report features of these hypersensitivities, so they cough more commonly to everyday stimuli. The exact mechanism of this reflex hypersensitivity, though, is quite unknown still. And I think that's quite an interesting area to look into in the future. We also know, all of us, that ILD affects the interstitial architecture with the abnormality. There's a theory and hypothesis that maybe it predisposes the stress receptors to be more sensitive and provoke cough. And indeed, a study done in a relatively small sample, albeit by Ron Eccles in Wales, showed that percussion of the chest is more able to elicit cough in patients with ILD and IPF than it is in healthy individuals. And the diagram sort of summarizes it on the slide. The other thing to remember is also that patients with ILD have comorbidity. For example, we know that they're more prone to have reflux diseases and also OSA, and those likely also contribute to the mechanism of cough. Next slide, please. So despite cough being quite impactful, likely associated with disease severity, and I hope I'm starting to convince you that it's a phenotype and that there's so much to still know about the mechanism of cough. Cough is actually often not very looked into very well in ILD. We know that antifibrotic medications are very effective, but we don't know what their impact and efficacy is in cough. Recent studies really have only been focusing on opioid-based cough therapy. This with only modest efficacy. And I think cough being really an area where it's been so far overlooked and under-investigated in ILD is summarized beautifully by this quote from the landmark symposium in 2023. I'm not going to read it out because I presume you guys can all read. I'll just pause for a little bit. And next slide, please. So if we want to investigate cough, I think the most important thing to think about is how do we measure it? We can't investigate anything that we can't measure. Just as with most other symptoms or phenotype within diseases, there are subjective and objective assessments. Subjective assessments being really patient-reported outcomes. We have disease-specific ones, so LPM, KBIL, KSQ for sarcoid, St. George's Respiratory Questionnaire, and so on and so forth. We have also cough-specific patient-reported outcomes. Cough's been investigated quite extensively on its own, initially as a symptom, but increasingly recognized as a disease uh, internationally. And there are severity tools. So, like I said earlier, visual analog scale is a subjective tool that assesses cough severity from 0 to 100, as per any other visual analog scales. And there are also specific tools to assess health status. So the LCQ, the Leicester Cough Questionnaire, is one of the more commonly used one. It's, as per most PROs, self-administered 19 items. PROs, however, do have some drawbacks. For example, they have prone to biases, including recall biases, and that's where objective assessments come in. Objective assessments certainly excel in this area and are not prone to any recall biases like PROs are. And one of the main things we can do is objective cough monitoring. Really going forward, I'm hoping to sort of convince you in the next couple of slides that really a complementary system of subjective and objective assessment is the way forward to assess cough, especially in clinical trials. Next slide, please. Technology is obviously improving a lot, but so far until very, very recently, really the main thing we look at when we objectively monitor cough is cough frequency. And that's really the number of times that we have that explosive expiratory phase of that cough that we're all quite familiar with and synonymous with coughing. And the number of times that we have those episodes over a predetermined time, which is usually 24 hours, is quite aptly termed cough frequency. And that's really been the main objective measure and objective assessment of cough. And that's been used extensively in most cough trials, and particularly even in recent ILD studies in IPF, for example, in Pacify and in Albumin, cough frequency has been a primary endpoint in those two studies. And this is where Clario and Stratos Lab also come in. Both Clario and Stratos Lab offer an FDA clear device, which is also CE marked for those of us in Europe. It's over 24-hour battery life, and it's an ambulatory non-intrusive device. You can see on the picture demonstrated. That device is able to capture the cough frequency relatively seamlessly with wireless data transfer as well. Next slide, please. But is cough frequency really the only measure that we're interested in? And quite simply, I'm baiting you with the question, and the answer is no. And as reflected through some of the items within our PROs that listed there in the LCQ, the LPF, and the SGRQ, you can see the different elements, different impact of cough, and they're being captured through these items within the PROs. The objective cough monitoring with solely just cough frequency is obviously very limiting and unidimensional. One of the advantages, in particular, of the Stratos Lab and Clario device is that there are other objective dimensions that can be measured. For example, the power, the intensity of the cough, how often and how frequent the cough are coming, which we tend to term as cough bouts. What about the impact, for example, activity level, sleep pattern, and what about audio autonomic dysfunction that it can actually cause? And I think the beauty is that going forward with advancing technology, these objective dimensions would probably play a role as well in complementing the subjective measures. Next slide, please. So I hope in the brief sort of 10 or so minutes, I've demonstrated that cough is impactful and that we should probably consider it more as a phenotype rather than just simply a symptom in ILD, and that cough in ILD are most likely or has the potential to be associated with severity of disease. It is hopefully, I've also convinced you that it's quite under-investigated and there's really an unmet need to investigate cough, in particular, cough-specific therapy in ILD. And we don't really know what the impact of these therapies are at the moment, in particular with disease severity. I've also hopefully explained to you that there are different ways to assess cough, including subjective and objective measure. And going forward, I personally believe a combination, a composite measure of both complementing each other with their respective pros and cons will be the way forward to investigate cough in ILD. And on that note, I will pass on to Amit for the next part of the talk.
Thanks, Peter. So I'm briefly going to cover medical imaging related endpoints in ILD. You can go to the next slide. As Todd and everyone else alluded to, there's a lot of different subsets within ILD. Most commonly, we see imaging studies related to IPF and sarcoidosis with a mix of like NSIP or nonspecific interstitial pneumonia. They have overlapping features, which makes it really difficult when you're trying to determine whether a subject is eligible for an IPF-based study. And I'll go through some of those issues. In terms of imaging modalities, HRCT is by far the most common. We do see quantitative CT, which is mostly used for emphysema, specifically around asthma and COPD studies. Chest x-rays are rare. You don't get the amount of information you need for quantitative assessment of fibrotic features for IPF. Very rarely we'll see MRI. There is a histopathology component. In IPF specifically, there are, if the HRCT is indeterminate for an eligibility call, we can have the site submit a biopsy and the pathologist can review it to determine if the subject does have IPF. And in the images shown here, there are some examples of features that are detected in pathology: fibrosis, honeycombing, and fibroblastic foci. Next slide, please. In terms of the requirements for studies, and I'm going to focus the next few slides on IPF specifically, although they do overlap with the other ILD indications. You want to make sure that you have counseling for the imaging protocols, that they align with the study protocol. Want to make sure that the imaging equipment is validated and qualified for the study. And that's typically fairly straightforward if they're using a CT scanner. It's mostly standard of care, except for the fact that you have slice thicknesses that are on the thinner side. You want to make sure that radiation exposure is accounted for. We do allow for some dose control on some of these scanners, but as long as they don't sacrifice image quality. And then in terms of image quality, you want to make sure that sites are submitting scans that adhere to the specified protocol. In most cases, we're not asking sites to repeat the scans because of the radiation dose, but we want to provide them feedback to make sure that on subsequent subjects or time points, they aren't repeating the same issues with their protocol. And then in terms of the centralized image analysis, I'll get to that in the next slide, but we typically have an eligibility time point where a radiologist will go through and review the HRCT and perform a semi-quantitative analysis for whether the subject has IPF or not. And then downstream, there's an AI-based segmentation and quantitative analysis for the fibrotic features. And we have a number of partners we work with that are listed here on bottom, not ordered in any preference, but they all have various methodologies for segmenting fibrotic features and defining percentages within the lungs. Again, they have different validation approaches to those as well. You can go to the next slide. So this sort of provides an overview of sort of the typical requirements for IPF. In terms of eligibility or inclusion, as I mentioned, HRCT is the primary methodology based on two guidelines, the 2018-2022 ATS guidelines from RAGU and that group. But it's a fairly straightforward in terms of the classification, in terms of the outcomes. So whether the subject has UIP, probable UIP, it's indeterminate, or there's an alternative diagnosis, not UIP. It seems simple, but again, because of the overlapping features with other shared indications in the ILD space, you can have some issues, and we typically see adjudication rates that can get to about 40% between radiologists. In addition to the classification, there's also a requirement or an ECRF question asking if the fibrotic changes are greater than the extent of emphysema. That's typically limited to 10%. And then in terms of the scans, we typically get a HRCT that's historical, acquired within 12 months from the screening visit. Those historical scans don't necessarily meet the requirements for the thin slice HRCT required for quantitative analysis. So if the subject is deemed eligible based off of the historical CT scan, we do ask the sites to acquire an on-study baseline scan that can be used to compare against any follow-ups. And typically the follow-ups are around 52 weeks or 48 weeks. We do see some protocols where the sponsor will ask for a 24-week in addition to the 52-week. We don't typically see changes in fibrosis within that time period. And IRBs may push back on that with the additional radiation dose. As I mentioned, the HRCT slice thickness is less than 1.5 millimeters, and it's usually full inspiration. We do have some sites that will do an optional expiration for air trapping, but it's not a requirement because of the additional radiation dose. And then in terms of the efficacy, again, it's quantitative metrics once the subject's enrolled, looking at IPF features that I'll get into in the next slide. So you can, next slide, please. The features that are shown here are sort of the hallmarks with the exception of ground glass. So honeycombing is the predominant feature for UIP or IPF, and you can see this with the arrow shown. They're cyst-like air-filled sacs, usually contiguous. They're predominantly basal at the bottom of the lungs and subpleural. You'll also see traction bronchiectasis, which are dilatations of the bronchial walls, and you can see that in the image here, and caused by retractile fibrosis. And then you'll see reticulation that's subpleural with these hallmark thick or thin lines within the lungs. And then with ground glass opacities, typically areas of patchy high density regions, sort of diffuse and hazy. They will, in IPF, they will overlie any of the fibrotic features that would be for a subject that has IPF. In the case where it's pure ground glass, so you don't see fibrotic features, which is shown in the inset here, that's a differential diagnosis, so that these subjects would not have IPF. Go to the next slide. So I'm not going to go through all of the different iterations of the classification, just cover UIP and alternate diagnosis. For UIP, as I mentioned, it's honeycombing that's predominant here, and it's shown in the top panel with the blue arrows. And there's two axial views cut across this coronal representation on the left side. So the upper part here, you don't see the honeycombing. On the lower basal portion, you see the honeycombing with the blue arrows. It can be a heterogeneous distribution, often diffuse and asymmetric. And then you will also see traction bronchiectasis that's shown in the bottom panel with the green arrows. You can see that thickened wall around the bronchioles. And then you would see some superimposed mild ground glass opacities as well with reticulation. Go to the next slide. This slide shows some examples of alternative diagnoses. Panel A, or the top set of three images, shows a coronal view with two slices. This particular subject has nonspecific interstitial pneumonia or an SIP. There's areas of marked ground glass opacification. It's uniform. And it's predominantly upper and lower lung as well. So it's sort of patchy, diffuse, as I mentioned in the ground glass example before. B here shows chronic hypersensitivity pneumonitis. There's air trapping that's shown with the lower density regions in the right lung there. C is also chronic hypersensitivity pneumonitis with a predominance of a mosaic pattern that's shown in C there. And then in D, this is also an NSIP subject, but you can see the reticulation, but there's an area shown by the red arrow where there's a subpleural sparing, which is indicative of NSIP. And then E is sarcoidosis. It's symmetric in terms of left and right lobes or lungs, and it's primarily around the peribronchial vascular regions. There are micronodules that are present all the way through. And then lastly, on item in panel F, there's the subject has pulmonary edema. You can see the patchy areas of ground glass. I can go to the next slide. As I mentioned, there's different terms for the AI-driven sort of quantitative analysis for fibrosis. This is an example from Vita. We don't have any preference, but this is just the example that I pulled up. Their reporting shows the quantitative analysis in terms of percentages for ground glass and reticulation, consolidation, which is a differential for IPF, and then honeycombing, which is one of the predominant features. And then you can see on the right panel here, a subject with scans from 4 years apart. You can see the fibrosis increasing over time, but you can get the quantitative metrics for each of those scans. The outcomes are typically total ILD score, which is a combination of all of those metrics, including consolidation, and then a fibrosis score, which is reticulation with honeycombing. There are different metrics for each vendor that we work with. You'll hear terms like quantitative lung fibrosis or QLF. There's a Fiber 8 score as well. So there's variants of those metrics. And again, our partners have different ways of generating those and then outputting them for and validating them for studies. I will put in a plug for one of our partners, Curate, that can do quantitative analysis on historical scans. So they have AI that can work on scans that don't have the necessary 1.5 millimeter or less slice thickness. I believe that's my last slide, and I'll pass this over back to Todd.
Just making sure that people can hear me. And actually, I see green, so I think that I'm being heard. So just to summarize, and thank you to each of our speakers today for a very informative presentation. But in summary, you can see here, obviously these diseases are associated with substantial morbidity and mortality. There's a continued and significant unmet need here. And despite advancements from a pharmaceutical standpoint, we clearly need more available to these patients. Clinical development, currently traditional endpoints remain at the fore, but important for us to enhance assessment of the patient experience through the PROs, through ECOA, and also to listen to the patient in terms of what it is that they deem important. This cough frequency and severity has increasingly been apparent, and so I think we've shined a light on that today, and hopefully can be incorporated into further assessment of future drugs in this space. Utilizing the ATS-ERS spirometric standards is very important to make sure we're maintaining quality, but we can enhance eligibility by individualizing and utilizing specific approaches, a modified approach, to help facilitate throughput into these studies and hopefully get therapeutics to our patients in a more quick fashion. And then finally, again, considerations about the cough. Assessment of frequency and severity, relying on diaries and recall, that's one means, and we can augment on that by applying advanced technologies. And so we certainly encourage taking that approach. And with that, I believe I am turning it back to you, Sonia, for opening the floor for questions and answers.
That is correct. I first want to say thank you very much, Todd, Kevin, Amit, and Peter, for that very detailed presentation. I hope everyone appreciated it. Now we're going to start the Q&A portion of the webinar, so I'd like to invite our audience to continue sending in their questions using that questions window if you're attending this by GoToWebinar. And for those of you who are watching on LinkedIn Live events, feel free to post your comments in the comments section. So while you were speaking, I did receive a bunch of questions, so let's start with this first one here. I think we might have time for maybe one or two. So here's our first question. This audience member is asking, with the emerging importance in AI ML and understanding that Clario has acquired Arctic, have you incorporated AI into clinical development support? If so, how? Sounds like it might be a long answer here, so go ahead. Who would like to take this one?
Well, I guess let me start. I don't know if others will have a comment. And as Amit has already pointed out, there's use of AI in interpretation of the imaging, and that technology has been present and utilized in our support of clinical trials over time. We have incorporated use in terms of optimizing recognition of quality of the spirometry and increasing the speed by which we can provide feedback to sites of the quality of that spirometry, which is very important. When you have a patient on site, you want to be sure that the spirometry that's being conducted or the PFTs that are being conducted are able to be utilized. And so that feedback can be much more rapid by use of AI. So that's both looking against ATS ERS standards, that's the more immediate feedback. And then also, as Kevin had pointed out about our emphasis on quality of spirometry, we are utilizing it as well to look at actually tracing by tracing the quality of the spirometric maneuver. And so we utilize it in that way. I think the question maybe has come, there was a recent BMJ article about use of AI in interstitial lung disease specifically. My answer up to this point is not ILD specific, but increasingly there's some recognition that perhaps diagnosis of ILDs can be augmented. That study, that report did indicate an improvement in performance by about 69% in the operator looking at the spirometry and interpreting it as most likely representing ILD. We have not yet incorporated that degree of that use case of AI into clinical development as yet, though we are in the process of further assessing the appropriate placement accordingly. I don't know if others have other comments. I don't know if Amit, you wanted to expand.
No, you covered it. I mean, it's there seems to be a new AI company every other month, coming up with a way to do their, at least for imaging, to do the analysis. But you have to make sure that you look closely at their validation and what studies they've conducted their training on.
Thanks.
Okay, I'm going to squeeze this last question in. Is the SVC an accepted endpoint for ILD? This audience member is asking.
I've not heard of it being used as an endpoint for ILD. I think that somebody's going to have to first use it as an exploratory endpoint and show its utility, which I think shows great promise. Again, a reduced burden, but until that happens, there's going to be a reluctance to sort of put all your chips on the table on a unproven endpoint, but there's no theoretical reason or rationale as to why it wouldn't work for ILD.
Okay. Anyone else like to comment on that last question? Nope. Okay. Thank you very much for that, Kevin. Well, thank you very much for answering all those questions. We have reached the end of the Q&A portion of the webinar. For those of you interested in hearing more from Clario, you can register for their next webinar, Keys to Success in Clinical Trials, a strategic guide for biotechs and startups, and that's scheduled for Thursday, May the 22nd, and I'm going to put the link in the chat box for you now to make it that much easier for you to register for this great discussion. Okay, and if we could not attend to all your questions, please bear in mind that the team at Clario will follow up with you. And if you have any further questions or inquiries or research information you're looking for, please utilize the email address you see there on your screen, and that's science@clario.com. Thank you, everyone, for participating in today's webinar. You will be receiving a follow-up email from XTalks with access to the recorded archive of this event. A survey window will be popping up on your screen, and your participation is appreciated as it will help us to improve on our further webinars. Now, give me a few seconds. I am going to share a link to view the recording of today's event in the chat box, which you can also share with your colleagues once they register for the recording here as well. So give me a few seconds, and I'll do that momentarily. So let me just do that right now as I'm talking about it. So here you go, everyone. You should see it appear there now. Okay. All right. So now, for those of you watching via LinkedIn Live events, we encourage you to visit xtalks.com to register for this event and gain access to features such as viewing the recording and more. Now, please join us in thanking our speakers for their time here today. So thank you very much, Todd, Peter, Kevin, and Amit for your time. We truly appreciate it. We hope you found this webinar informative. It has been my pleasure to be your webinar moderator. On behalf of the team here at X-Talks, we thank you for joining us. I'm Sonia Hunt. Until next time, please take care and bye for now. Bye, everyone.
Bye-bye.
Bye.